There's no study that proves that the spread of COVID-19 in vehicles is high. That's the response by the Director General of the Ghana Health Service, Dr. Patrick Buaje, to concerns being raised over commercial vehicles being allowed to resume operations at full capacity. According to Dr. Buaje, there is a less likelihood for the virus to spread if all other protocols are observed. We'll hear from him shortly on that. But first, he announced that the country had recorded 782 new cases, taking our total case count to 34,406.
Conducted 382,752 tests, bringing our tests per million population to about 11,792, which is relatively quite high by all standards. Based on this, we have a test positivity average total of 8.99%, 8.57 from contact tracing, and 9.71 from routine surveillance, which is to be expected. I just want to talk about the positivity rate. Is that it depends on the testing strategy. We are now moving more to, because we've done a lot of the risk assessment, we've done the sweeping, and so we are doing more targeted testing, which means that people who are showing symptoms and their contacts and high risk groups. So you expect that because you are targeting specific group, your positivity will be higher than when we started with the 2%, etc., because we're doing a larger group. We are reporting a total of 782 positives this morning, and these samples ranges from 23rd of June all the way to the 25th of July 2020. What it means is that as far as today is concerned, the most relevant positives are those who were taken about 2 weeks ago, and so a significant number of these people may have already recovered. Of the confirmed cases, they came from the 782 came from 58 districts and 7 regions. 30,621 have recovered, accounting for about 89% recovery, and so that brings out the total of 3,617 active cases. As we keep saying, active cases are the most important figure we need to focus on. These are the people we can say today they are carrying the virus, and like I said, if you compare this with malaria, we record about 800,000 cases of malaria every month. But I think we focus on who has malaria today, and that is the same analogy that we're trying to draw. The recoveries are significantly up, accounting for almost 89% of all the cases, and you can see that the active cases continues to stay quite low. Of course, it changes. Tomorrow, depending on the number of people who are recovering, we may have a much lower active case today, and that's what we should really focus on. And now we are doing about 11% of all our cases that are active. The rest are all, I would say, have recovered. And that shows in the graph, continue to show a downward trend, been high in the early parts of the distance, and then way back in the middle of June, we saw the decline and the continued decline that continued to show we're having that. So we need to focus on active cases, because that's where we need to respond with our healthcare services, our beds, our contact tracing, etc. This is where the main activities are as a nation. That's what we need to continue focus on.
Dr. Patrick Buaje there. He's also been responding to concerns about the easing of restrictions within the transport sector.
The transport, I think I'll explain how you can contract the disease. It can be from contact with true fomites, and then you put on your face or whatever, and in your orifices that you're able to get. There are also droplets that also comes from the person who is positive. And these are from your breathing, your speaking, your singing, etc. And so the risk of infection is first by close contact, and also by very close, and then the respiratory activity. So if you look at other places, when you are talking, when you are singing, when you are shouting, you are expressing more viruses, and so the risk of contamination is good. What we also know about transportation is that besides the social distancing, the cleaning of surfaces, etc., is routine. The wearing of masks is routine. But we also know that activity in a car is not like in other places. And based on our own experience in all our contact tracing we've been doing, we've had several instances where we have picked a positive case who was in a vehicle. Bono is to Wa, in so many of these places, and we have not been able to identify anybody who became positive because he was in the car with these people. Someone had traveled all the way from Accra to Wa, and several instances. So the evidence we have here doesn't show that the risk of transfer in the car is that. So that's why, with the wearing of masks and the cleaning of surfaces regularly, the risk of transfer or contamination in a vehicle is reduced, and that's what informed the decision to allow for that to take place. But of course, we'll continue observing.
Dr. Patrick Kumabuaje there. But Ghana's quest to have a quicker and efficient testing may tarry a while because the FDA says all 34 rapid antibodies diagnostic tests have failed their test. Mimi Dakon is the Chief Executive Officer.
From 16th April 2020 to 17th July 2020, we have received 34 RDTs for validation. These RDTs have come in from Ghana, one from Ghana, China, USA, Canada, Korea, Finland, Malaysia, Singapore, and the UK. I will just give you an idea of what we have so far for all of them. Taking all of them into consideration, we have a specificity of between 85 and 99%, and a sensitivity of between 4 and 54%. Please bear in mind that I said an RDT that is validated should be 99% before it is considered acceptable for use. Now, the sensitivity of an RDT when it is done and when it is considered acceptable is that the sensitivity test is done, and it is what identifies people who are positive for the disease or who have previously contracted the disease. So if you say that a test is sensitive, it means that it is called a true positive. It means when you test somebody who is considered sensitive, they would have had the disease before or they are currently having the disease. The specificity of an RDT determines people who have not been exposed before. So it is what we call the true negative. Why do we require an RDT to be highly sensitive? If an RDT is highly sensitive, it means that all the true positives will be captured. If it is highly specific or specificity, it means that all the true negatives will also be captured. So the fewer false results you have, the better it is for the population. Antibodies tell us who has had the virus and how far wide it is spread. Yes, it is a quicker method to use than maybe the PCR. It is some of them 15 minutes and you have your results. However, for an antibody test to be useful, we need to be able to trust the results that they give. Currently, considering that most of the people who are having or who get COVID are showing no symptoms and or showing very few symptoms, this is the more reason why a highly sensitive RDT is most important for this population. So as of now, all the RDTs that we have tested are ranging between 4% and 54% sensitivity and 85 and 99% specificity.
So let's have a conversation on easing of the restrictions. Should we be concerned? Should we not? What can we do? Because whether we like it or not, the decision has been made. Joining us on Zoom for this conversation is Dr. Benedict Calistego. He is an epidemiologist and senior lecturer at the University of Ghana Medical School. Doc, thank you for your time. It's been a while. Good afternoon.
Good afternoon, and thank you for having me.
Very well. So I just want to find out what your perspective is, whether you've been able to do any assessment. So Dr. Patrick Boaji, who is the Director General of the Ghana Health Service, says that based on their contact tracing, they can, at this point, confidently say that there is, in his word, I think he's saying that there is reduced risk as far as people sitting in a bus. What's your assessment? Reduced, non-existent, high, medium? What do you say?
Well, I find it very interesting. And I take that submission with mixed feelings. Because, you know, if you look at a typical trotro system and the duration of time we spend in that trotro and the closeness we are to one another, I don't know how many samples they worked on to be able to arrive at that conclusion. But if you look at the risk of transmission, one, it has to do with contact. Two, it has to do with the duration of the contact.
Okay.
And an average journey in the trotro from, let's say, Kaswa to Accra on a typical working day morning will take you nothing less than an hour and a half. So assuming you are sitting in this trotro with a positive case, bear in mind that most of our cases are asymptomatic. So you have no way of assessing whether the person sitting next to you is positive or not. It leaves me with mixed feelings. And it makes me quite uncomfortable. Again, when you talk about the fact that there is reduced risk, so in the trotro, we are allowed to breach the social or physical distancing directive. However, when we are out of the trotro, we revert to social distancing. I find that as a double standard. So it makes me very uncomfortable.
Double standard, you say. But don't you get a sense also that the societal psyche seems to want to accept this kind of analysis, especially with those who work within the transport sector? For them, this is business. And they've seen politicians going about their business anyway. They've seen churches being opened anyway. Is the societal psyche not important when we're making all these analyses and decisions?
Well, you make a very good point when you talk about societal psyche and the fact that we are seeing things going on business as usual. I mean, for the transport operators, yes, it's an opportunity to cash in. They are going to make more money because now they are going to take more people. But if we are looking at it purely from a public health perspective, then it's problematic. Because you see, we talk about the fact that some studies have been done or some observations have been done which didn't show high risk. Who goes around monitoring how often the surfaces in our trotros are cleaned and whether they are cleaned at all? When a trotro moves from one destination to the other and parks, who ensures that the trotro is cleaned before the next person gets on board? And if you know the way our trotro mates shout, I mean, that tells you something. So if you say that in the trotro there is minimum talking, there is minimum shouting, I beg to differ. You see how some of our trotro mates can shout. And it's continuous throughout the journey. And you are going to sit in this vehicle sometimes an hour and a half, and we can't trust the ventilation in all trotters. Some have their windows partially opened, some partially closed, some you can't control. So you are left at the mercy of how these windows are fitted. And so I find it a bit problematic when in one vein you are encouraging people to pack like quote unquote sardine in their trotters, yet when they go to other places, you are directing physical distancing. I find it a bit problematic.
Okay. Is that a conversation that we as, the society should be focusing on, trying to do the comparison between what politicians at their rallies or at their programs can do, what the church can do, and what the trotters can do? Or should we just now take the opportunity to encourage people to wear their masks and to be extremely careful, especially if they're going to be sitting in a trotro, for example?
Well, it's unfortunate that almost every conversation in this country has to go down political lines. But the truth is that when you look at the reality on the ground, the fact that politicians are doing something which is untoward doesn't mean it should be licensed for everybody to do it. And there are people who have the opinion that even the easing of these restrictions have some political undertones. I cannot validate that. I don't know. But the truth of the matter is, when we are coming up with these policies, we should make sure they are really for the public good. That is where I want to come in from. So it's not a matter of because politicians are doing it or because churches are doing it, so vehicle operators should also do it. Where does it leave us as a country? You know, we are dealing with a virus we know very little about. Knowledge is evolving as we go along. New modes and means of transmission are being discovered every day in and day out. And if you look at the basis of some of our arguments, I have issues with them. For instance, when we talk about, the Director General talked about we focusing on the active cases. Let's bear in mind that our testing strategy has changed, like he rightly said. Previously, we were doing more aggressive testing. We were doing what we call the enhanced surveillance. Now we are doing more targeted testing. And so we are not testing as aggressively as we used to. Secondly, we have a lot of our populations being asymptomatic. In other words, they are not showing any signs and symptoms. So invariably, the people we are picking up are the so-called high risk. What about the greater majority who are walking around without symptoms and they are with us in our churches, in the trotros, in our homes, wherever? So we need to be careful. When we talk about active cases, those are the ones we've been able to diagnose. And I would refer to that as the iceberg syndrome. So we are just seeing a tip of the iceberg. The bulk of it is beneath. And if we are not careful, it will come back to haunt us. Because there are people who have not been tested because they are not in the high risk group. So let's be careful the way we interpret these things. As of now, as a country, we cannot say for sure what the number of daily new cases are. We can't say for sure because we always have a backlog. And if you listen to the director, the figures he put out today were samples, some of which were taken as far back as 23rd June. So if we are now reporting on data from 23rd June, whilst they were waiting for these results, what were these people doing whilst waiting for their test results? Were they in isolation centers? These are the things we should be worried about. It is not okay to just look at active cases from an epidemiological point of view. It is not okay.
Okay.
We should be interested in the incidence, i.e. the number of new cases we are getting on a daily basis. Because the active cases we are getting are just a tip of the iceberg, and they may be very misleading.
Right.
So I beg to differ on that count.
Very, very well. I'd like you to end for us, a bit of an advice for what a typical trotro or taxi user can do in these times. But Dr. Kumar-Boakye indicated that, we know that it is spread through contact, through droplets, which you also said. But we know from the beginning that we're still trying to find out, really understand this virus and the way it behaves. What more do we know that's different from what we knew back then?
Well, there are new evidence coming up. In fact, the latest is that this virus can actually be transmitted fecal-orally, i.e. through stool. These are new things coming up. There are evidence to that effect. And we don't know what next it will be. But my advice to everybody who would have to join a public transport is that just like any other Ghanaian, your safety lies in your hands. The politicians can give directives, but your safety lies in your hands. So everybody should ensure that they are wearing their mask as they should. Make sure you carry your own sanitizer at every point in time. When you enter, after touching the doors, you sanitize your hands. After paying and collecting your change, you sanitize your hands. As much as possible, make sure you keep your hands to yourself. And pray that you are not sitting next to a positive case.
Pray that.
Because that is the reality. Most of our people are asymptomatic. So you can't tell who is positive and who is not positive.
Well, people have said that whether we like it or not, this is here with us. We're not the only ones that are overwhelmed with it. So we're essentially just doing our best. You think there's something else we could have done better?
Well, I think we should have been more calculated with the easing of the restrictions.
Okay.
I don't know what is informing this at this point in time, but I think we should have been more calculated. And, 2 days ago, I was in my house when I overheard an announcement from Zoomlion. So I got curious. I got out to find out what was happening. And here was a COVID-19 branded vehicle being used to make public announcement for Zoomlion to come around and collect waste. Throughout this outbreak period, I have never seen a van in my area educating the populace. I have never seen one. And yet, they could use that same vehicle, COVID-19 branded, for advertisement for Zoomlion to come and collect waste. I think we are not doing the right things. We are not doing public education as we should.
Right.
I am not feeling the presence of the NCCE. I am not feeling the presence of the Information Services Department. I am not feeling the involvement of our traditional rulers. Just imagine the impact it will have if, let's say, Otunfo comes out to give a statement encouraging everybody to wear masks in Kumasi, for instance. Just look at what will happen if our traditional leaders are really brought on board to get involved. One can argue that, well, they don't need to wait to be brought on board, but that's where leadership comes in. If people are not coming on board voluntarily, it behoves on leadership to galvanize the needed support. I don't think we have done enough with respect to our education. Prior to easing these restrictions, one would have expected that there would be intensified education to let people know that, yes, life must go on. We need to open up our economy, and therefore there will be easing of these restrictions, not because the virus is over, not because we are out of the woods, but because life must go on. I mean, we all agree to that fact. We cannot shut down our economy ad infinitum. But then we would have to open up advisedly and let people know, because you walk through town and the general impression is that, oh, it's business as usual. And some will tell you they don't even believe in this COVID-19 because of all that is happening around it. So I think there is a lot we can do by way of public education. There are no pharmacological remedies as at now. There are all sort of claims going around. So what we need to do is to adhere to these non-pharmaceutical measures: hand sanitizing, washing with soap and water, use of sanitizers, the wearing of the face mask when we find ourselves in public places, and as much as possible, maintaining that physical distance. I don't see how we can maintain that in the trotro. And it's a problem for me.
Right. I hope that we can get around this. So I can add to that essentially. But Doc, thank you so much for your time this afternoon. Dr. Benedict Kalistego is an epidemiologist and the senior lecturer at the University of Ghana.